Hello, my name is Francisco Bergen. I am a fourth-year Doctor of Pharmacy candidate from Florida A&M University. Today I will be performing a journal critique on the initiation of antiretroviral therapy in early symptomatic HIV infection. This study is listed in the New England Journal of Medicine and was funded by the National Institute of Allergy and Infectious Diseases and others. Now, some background on the study. Human immunodeficiency virus, also known as HIV, is a disease chiefly characterized by the loss of CD4 cells. With this loss comes an array of HIV-associated complications that increase as the CD4 cell count decreases. In general, the initiation of antiretroviral therapy is deferred or prolonged in patients that are asymptomatic and have a CD4 count above a certain threshold. That being said, the primary reason for this study was to assess the difference in outcomes in patients that initiate antiretroviral therapy at a higher CD4 count versus patients at the current standard. Another reason for this study is that prior to this study there was a lack of information and evidence on the benefits and risks of initiating antiretroviral therapy in patients with asymptomatic HIV infection who have a CD4 count greater than 350 cells per cubic milliliter. Most studies prior to this one enrolled patients that had CD4 cell counts lower than 500 cells per cubic milliliter and used the later threshold or the prolonged threshold as a CD4 cell count between 200 and 250. Furthermore, most studies regarding HIV research have been more focused and reviewed the risk of acquiring HIV and death due to HIV rather than addressing patients currently with HIV and the possible alternatives for better outcomes. Hence, this study was constructed. So, due to the apparent gap in evidence, as I stated earlier, the International Network of Strategic Initiatives in Global HIV Trials, also known as INSIGHT, designed the START trial. So the START trial stands for Strategic Timing of Antiretroviral Therapy. This trial would help answer the question which I kind of pointed out earlier, which is to determine the risk and benefits of immediate initiation of antiretroviral in asymptomatic HIV positive patients who have a CD4 cell count more than 500 cells per cubic milliliter as compared to deferring initiation until the CD4 cell count drops to 350 cells per cubic milliliter. Now, to expand more on the study design. In the construction of the study, INSIGHT designed a multi-continental randomized study. The study evaluated two strategies for initiating antiretroviral therapy, both of which I pointed to earlier, one being the immediate initiation and the other being the deferred initiation. The deferred group refers to the group that would delay initiation until the CD4 cell count dropped to 350 or an age-related event occurred or another condition that occurred that dictated initiation. Now, to point out an interesting decision of this study, the study was initiated back in 2009 in complete compliance of the recommended guidelines. As the study progressed, the guidelines began to become revised and they begin to change the guidelines to better assist the HIV patients, but there were some inconsistencies with the guidelines. So what this study elected to do was to maintain the course that they've already started. So they continued administering or going by the guidelines that were in place back in 2009. So back to the study design. In order to be enrolled into the study, the patients had to be HIV positive. They had to be 18 years or older. They had to not yet be initiated on antiretroviral therapy. They had to have no history of AIDS, and also had to generally be in good health. Another thing they had to have two CD4 cell counts that came back with more than 500 cells per cubic milliliter that registered about at least 2 weeks apart, and both of those results had to come back within 60 days of enrollment. Women who were pregnant were not eligible for this study. However, If you weren't pregnant and became pregnant during the course of the study, then you are allowed to continue. So now, moving into the study endpoints. The primary endpoint was built into a composite outcome. A composite outcome is basically where multiple endpoints are combined into one. The multiple endpoints are assessed by first occurrence. So the two major components of the composite endpoint in this study were any serious age-related events, which included death or any age-defining event, or any serious non-age-related event such as cardiovascular disease, end-stage renal disease, liver disease, cancer, or death from any of the following I just mentioned. So one thing that the study also, interestingly enough, decided to leave out was the study elected not to include non-fatal herpes simplex virus infection or esophageal candidiasis due to their lack of severity. So, and all through the study, there was an endpoint committee that was responsible for reviewing all reports of serious age-related events and serious non-age-related events. The people involved in the committee were unaware of the study group assignments, and their evaluation criteria was already pre-established. So they were able to keep the committee blinded and kind of reduce the amount of bias that would be introduced into the study. Secondary endpoints included serious age-related events, serious non-age-related events, death from any cause, grade 4 events, and unscheduled hospital events. Grade 4 events were defined as potential life-threatening symptomatic events not attributed to AIDS, but that required medical intervention. So moving on to the statistical analysis. The two groups were compared to the intention to treat principle. So what does that mean? Intention to treat means all patients who were enrolled and randomly allocated to treatment are included in the analysis and are analyzed in the groups to which they were randomized. The two groups used a time to event method, which included the Kaplan survival curve and the Cox proportional hazard models, to compare the two groups for the primary endpoint. So what are those models and what do they mean? So just to go real brief, the Cox model, which was used in the study, provides an estimate of the hazard ratio and the confidence interval. The hazard ratio is an estimate of the ratio of the hazard rate in the treated versus the control group. In other words, the hazard ratio describes the relative risk of a complication based on comparison of event rates. Now, when recording data for the study, the process of recording data may be affected by subjects that are uncooperative and refused to be remained in the study, or when some of the subjects may not experience the event or death before the end of the study, although they would have experienced or died if the observation continued. Or, which happens very commonly, you lose track of patients partway through the study and you can't find them. So for those circumstances, we use the Kaplan-Meier estimate. The Kaplan-Meier estimate is the simplest way of computing the survival over time in spite of all the difficulties associated with subjects or situations. Both of these tests were used in the study in order to promote the most accurate data. Now for the results. The study took place between April 2009 through May 2015. The study randomly assigned 4,685 patients to receive immediate antiretroviral therapy or deferred therapy. After randomization was complete, there were 2,326 patients in the immediate treatment group, and 2,359 patients in the deferred group. There were a total of 215 sites in 335 countries. The two groups were distributed pretty evenly, and there were 27% females. The median CD4 cell count was 651, with counts as high as 2,296, and in regards to the follow-up, the mean time was 3 years. As of May 2015, antiretroviral therapy had been started on 98% of the immediate group and 48% of the patients in the deferred group. The drugs that were primarily used in the initial treatment were tenofovir, emtricitabine, and efavirenz. Something to take note of in the results was that and after the first year of randomization, the CD4 cell counts in the immediate treatment groups markedly increased and continued to gradually increase after the first year. Conversely, in the deferred group, the CD4 cell counts decreased in the first year because they were not receiving any treatment. So they actually decreased in the first year, and upon antiretroviral initiation, once the CD4 count dropped to about 350, it only stabilized the CD4 cell count, and then it began to slowly increase thereafter. So just in that statement alone, you could see the benefit of starting the antiretroviral therapy earlier versus later. So for the study endpoints, the composite endpoint in the immediate treatment group occurred in 42 patients, which was 1.8% of that population, or you can list it as 0.6 events per 100 persons. The composite endpoint for the deferred treatment group occurred 96 times, which is 4.1% of that population, or you could term it as 1.38 events per 100 persons. The hazard ratio in the immediate group as compared with the deferred group was 0.43 with a 95% confidence interval of 0.3 to 0.62, and the p-value with a p-value of less than 0.001, therefore making it statistically significant. These numbers translate into the immediate group having less than half of the composite endpoint due to the pharmacological intervention at an earlier stage of HIV progression. Now, for a summary of primary literature outside the study. There was a similar study titled Early versus Standard Antiretroviral Therapy for HIV-Infected Adults in Haiti. They performed a similar assessment on the initiation of antiretroviral therapy in patients with HIV. In this study, the CD4 cell count was much lower, though. Like I said, this is the first one to actually consider 500. So in this assessment, they were comparing whether to initiate antiretroviral therapy at 350 cells per cubic milliliter or to defer to 200 to 250 cells per cubic milliliter. The results of this study strongly supported the initiation of antiretroviral therapy in patients with 350 cells per milliliter. In this study, they were able to show a decrease in death by 75% and a decrease in acquiring tuberculosis by 50%. It was this study that the premise of raising the CD4 cell count for initial therapy was constructed. One of the downfalls of the study that I just mentioned was that it was not blinded, so therefore they could not eliminate the potential bias that may have ensued in the results of the secondary endpoints, but nonetheless it was a great study to build off of. So in conclusion, I guess to wrap up everything that I've just said, there is a benefit to administering the antiretroviral therapy to CD4 cell counts greater than 350 per cubic milliliter. Per the results of the study, administration of antiretroviral therapy in the earlier stages in HIV has shown to lower the risk of serious AIDS-associated events and non-AIDS associated events. So, and that's basically the end of the study. So, what do I think of this study? I thought the study was fantastic. It had a great number of people. It was all over the world, so it really accounted for, it was really able to account for disparities in different areas or different results. One of the weaknesses that I did see in the study, which they couldn't really help, was the time of evaluation. People will be taking they did a 3-year follow-up, whereas people that have HIV will be on that therapy for the rest of their life. So if anything, I would continue the evaluation, but 3 years was sufficient. I thought overall the study was fantastic. So thank you for tuning in to me. I hope you enjoyed.